To start with the next session, may I please request Dr. Ranjan Sharma, Dr. Prakash Hajra, Dr. Shoujatto Chakraborty, Dr. Shubhashish Roy Chaudhary, and Dr. S.B. Nagori to join the session as our respected chairpersons and panelists. And the first speaker for the next session would be Dr. Imran Ahmed. Requesting Dr. Imran Ahmed to begin with his presentation and requesting all the chairpersons and the panelists to allow him to begin with his presentation and talk. Thank you. And as we all know that we will have 15 minutes time of discussing all the cases at the end of each session. So if you have questions, if any, to discuss, kindly hold on to them until we finish all 3-4 speakers dedicated in each session. Thank you.
Welcome, Imran.
Yes, good morning, sir.
Yeah, very difficult topic. RV failure, and we have limited evidence.
Pulmonary hypertension, pulmonary management of severe pulmonary hypertension and RV dysfunction. Yeah. So I'll just try and share the screen. I'm having some disturbance with my PowerPoint. I mean, the laptop. Hopefully, it will play. Sir, is the screen visible?
Yes, yes.
So it's recent trends in management of pulmonary hypertension. I would just ask the organizer if there is a problem. I have already emailed the slide so they can play the slide if there is a problem in my presentation. So as regarding the definition and classification of pulmonary hypertension, let us first understand one thing, that the presence estimates is that a PH prevalence is almost 1% of the global population, and this is a rising figure because of the contribution of cardiac and pulmonary causes of pulmonary hypertension. Globally, left heart disease is the most common cause of pulmonary hypertension, and followed by the lung disease, that's COPD. And the definitions, if you want to define that, it has to go through the right heart catheterization. Hemodynamics represents a central element of...
The slides are not moving.
Okay. Is it, sir?
Oh, yeah, you are on the first slide only.
Okay.
You can see only the first slide.
This one, definition and classification, not come.
Oh, yeah, it has come. Then go to slide show more.
Well, I think we have to go with this, sir, because if I'll try and go to slide share. Yeah. Is it coming in slide share?
No, slide show mode.
No, slide show mode, is it coming? I have done it slide show.
Okay.
Anyway, let me go by the I think this is visible. Is this visible? Definition and classification slide?
Yeah, that slide is visible.
So will that be okay? It's or you want me to go to the slideshow mode?
Okay, we can see.
No okay. So after the initial introduction, the definition of pulmonary hypertension would be a mean pulmonary arterial pressure more than 20 millimeter. So across the board, mean pulmonary arterial pressure more than 20 millimeter as pulmonary hypertension. Once we call a condition called the isolated post-capillary pulmonary hypertension, that is due to left heart causes. There, the mean pulmonary arterial pressure should be more than 20 millimeter, but the pulmonary artery wedge pressure should be more than 15 millimeter. So in a pre-capillary PH, the pulmonary artery wedge pressure should be less than 15 millimeter, but due to left heart back pressure, the pulmonary artery wedge pressure more than 15 in a post-capillary pulmonary hypertension. So these is an exhaustive clinical classification of pulmonary hypertension. We know that group 1 is pulmonary arterial hypertension, group 2 is those with left heart disease, group 3 associated with lung disease, group 4 with the pulmonary artery obstructions, that is chronic CTEPH and other pulmonary artery obstructions, and then group 5 is the miscellaneous causes. So this is a clinical classification. Most common, of course, is those with left heart disease, and then it would be with the PH associated with lung disease. And of course, you have the idiopathic pulmonary arterial hypertension too. So a little bit of a group 1 PH, it's more female predominant, and the hereditary PH affects twice as many females as males, and it is being frequently diagnosed in Western countries, and a number of drug and toxins can also be related to causing pulmonary arterial hypertension, and we should be knowing it once we are evaluating a patient pulmonary arterial hypertension. The definite association with those of these drugs like fenfluramine and dexfenfluramine and methamphetamines, and then there's a possible association with alkylating agents like cyclophosphamide, a few anti-cancer drugs. So these have association in this list, as you can see, with the pulmonary arterial hypertension. Group 2 is those with heart failure, that's left heart disease, and most of them are aged in this case. So normally idiopathic pulmonary arterial hypertension is slightly younger group, but in this group, it's the aged group more than 65. Post-capillary PH is frequently associated with pre-capillary. So that occurs in almost 50% of patient. Group 3 is those with parenchymal interstitial lung disease, as I mentioned, and group 4 and 5 as CTEPH and miscellaneous causes. Now, going into evaluation, the symptoms evaluation is important. As you can see, the symptoms would be initially a dyspnea on exertion, fatigue and rapid exhaustion, dyspnea when bending forward. Now, bendopnea for the last 10 years is now recognized by ACC and ESC as one of the causes. So any respiratory distress occurring within the first 30 seconds of bending forward, that's bendopnea, and it's associated with LV dysfunction or pulmonary arterial hypertension. Palpitations, hemoptysis can occur, exercise, abdominal distension, weight gain, syncope. Now, rare symptoms due to pulmonary arterial dilatation would be an exertional chest pain because of this is an enlarged pulmonary artery compressing the left main coronary artery, hoarseness due to Wagner syndrome, and shortness of breath, wheezing, cough, that's compression of the bronchi. So that can all occur due to dilatation of the pulmonary artery. We know that. So signs of PH would be central or peripheral or mixed cyanosis. The P2 is loud, RV third sound, systolic murmur of TR, diastolic of PR, and signs of RV backward failure, like extended jugular veins, very important, abdominal distension, hepatomegaly, ascites, and towards the underlying cause of PH. So clubbing, cyanotic indicates a cyanotic heart disease or chronic lung process like bronchiectasis, differential clubbing, EPD, Eisenmenger syndrome. We can have a lot of scleroderma has a typical features like Raynaud phenomenon, digital ulceration. RV forward failure features would be peripheral cyanosis, dizziness, pallor. So that's decreased cardiac output status. So once we go to the evaluation, ECG, as you can see, the features of RVH, right bundle branch block, and RV strain patterns. And in V1, V2, V3 with RVH, you get a STT inversion. Now, to the X-ray, you can have features of pulmonary hypertension and concomitant abnormalities like right heart enlargement, the pulmonary artery, the pulmonary bay is enlarged, pruning of the peripheral vessels showing that there is the increased pulmonary arterial pressure, and signs of left heart disease can occur like central airspace opacification, curly B lines indicating of chronic pulmonary venous pressure increase, and signs of lung diseases which can contribute, like the features of COPD, emphysema. And this is a wonderful slide of the echocardiographic features. I don't know whether it's visible clearly or not. It's first would be the enlarged right ventricle in plaques view, dilated RV with basal RV by LV ratio more than 1 in the 4-chamber view. Then we move on to the flattened interventricular septum, D-shaped LV, distended inferior wall with this is the IVC, which is distended, and diminished inspiratory collapsibility occurs here. RVOT acceleration time less than 105 in the CW or the PW, if we can put it in the pulmonary valve. There's a reduced right ventricular fraction area change less than 35%. TAPC is decreased peak systolic. This is the tissue Doppler, the S wave is decreased less than 9.5. Enlarged right atrial area more than 18 centimeters square. Increased systolic peak, that's the TR velocity we calculate. Then the peak TR velocity with the right atrial pressure will give you the pulmonary artery systolic pressure. So if the jugular vein is more than 2.1 centimeter with a less than 50% collapse, that means you have to add 15 millimeter to the TR gradient. So that's how you calculate the pulmonary artery pressure. And then, of course, pericardial effusion indicates severe pulmonary artery hypertension. Ventricular perfusion lung scan is important to detect lung causes, especially CTEPH, where the thrombus can be detected in pulmonary artery. The CT signs of pulmonary hypertension in large pulmonary artery diameter and PA to aorta ratio 0.9 in enlarged right heart chambers. It's a combination of 3 parameters, which is the PA diameter more than 30 millimeter, RVOT wall thickness more than 6 millimeter, and septal deviation more than or equal to 140 degrees. That's in the M mode section or in the plaques view, septal deviation more than 140 degree, that indicates of pulmonary hypertension, and CTPH I have mentioned. So hemodynamic characteristics is important to define. So for right atrial pressure, normally 2 to 6 millimeter, and pulmonary artery, the mean pressure is 8 to 20 millimeter mercury. But if it's above more than 20 millimeter, then in that case, it's pulmonary arterial hypertension. Now, contraindication to catheterization would be a known thrombus or tumor in the RV or RA, recently implanted pacemaker, mechanical right heart valve, tricuspid clip rarely, and an acute infections are contraindication to right heart catheterization that we need to know. So, and then for systemic sclerosis, annual evaluation, the more frequent evaluation with conditions like systemic sclerosis and CTEPH, and vasoreactive testing is restricted to those. So vasoreactive testing can be done in with idiopathic pulmonary hypertension, but with left heart disease is only restricted to those who want a heart transplantation. So, and that can be done with nitric oxide, iloprostanol, and if you see now let's go to the treatment part of it. So as we see, the three main pathway of causing pulmonary hypertension: endothelin pathway, the nitric oxide CGMP pathway, and the prostacyclin pathway. All molecules are there which can counteract these pathways. Now, before we evaluate, you need to understand what is low risk, intermediate risk, and high risk. And according to that, the treatment modality is a single drug, double drug, or a drug with IV or parenteral modulation combination, depending on low risk, high risk, intermediate risk. Now, if we move on to, the low risk, intermediate risk, and high risk, as you can see, the signs of right heart failure, if it's present, then high risk. Progression of symptoms in clinical management, syncope, the World Heart, WHO, I think I'm having a disturbance with my PPT. Can we get back to the, can I get the slides from the organizer? Ujjal. Oh, no. You have to go back.
Dr. Ahmed, your topic was actually right ventricular failure with pulmonary hypertension. If you could just go to that section, that would be very useful because you don't have much time left.
Go to the management of RV failure with pulmonary hypertension. That would be better.
No, I think I got was, sir, regarding my recent trends in management of severe pulmonary hypertension with RV dysfunction.
I don't think so. Anyway, it doesn't matter. Okay, go ahead.
So I will just go through the. You can just go back few more slides, since this is also important. I think.
Yeah.
The management of severe pulmonary. So just go back, please, fast. Right. So I think we have all the molecules. Like, let's just go back one more slide, please. Whether it's right. So endothelin receptor antagonist. So first we need to find out whether it's low risk, intermediate risk, high risk, and then we have these molecules, the endothelin receptor antagonists. Next slide, please. Next, phosphodiester 5 inhibitors. We know all these. Riociguat is there. It's the latest molecule. Next slide, please. And prostacyclin analogs like ipoprostanol, iloprostanol, inhaled one. Next slide. So selexipag is the selective prostacyclin receptor agonist that's chemically distinct from prostacyclin. So that's there also. The side effects of these molecules: allergic reaction, headache, diarrhea, nausea, jaw pain. Next slide. So the ambition trial showed that combination of endothelin receptor antagonist and PDE5/1, that is ambrisentan with tadalafil, is effective, and it increases the life also. Next slide. So in those with intermediate low risk, we can have the ERA and PDE5 combination therapies. But those who are with intermediate high risk group, we can add IV ipoprostanol or IV or subcutaneous treprostinil into the combination, and then refer for lung transplantation. Next slide. So the pulmonary, the dosing of is there, so that's available in the slide. So let's go to the next slide. So interventional therapy, when there is severe pulmonary hypertension, balloon atrial septostomy and port shunts is there, and by creating an interatrial shunt, we can connect the left atrium, left pulmonary artery and descending aorta, and that will decompress the right heart and increase systemic blood flow, improving oxygen transport. As these procedures are complex and so the high risk, they should be done in a center which is which are adept at handling these patients. Next slide, please. Pulmonary artery denervation is there, the PADN trial. Now, the contribution, it's based on the increase in sympathetic overdrive characteristic pulmonary artery hypertension is associated with poor outcome. Now, the contribution of this mechanism to develop PH is not completely understood, and it is associated with vasoconstriction. So, this PH is associated with vasoconstriction, vascular remodeling through a baroreflex mediated mechanism. Applying radiofrequency should therefore decrease chronically the hemodynamic variables. But the multi-center RC demonstrates benefit of PADN, but that is the evidence is not very strong, and we have got trials showing the benefit, but the evidence is not strong enough, but it is being used in a lot of centers. Next slide. Sotatercept is a new molecule in this, that's the mutation in BMPR2, as we know, is an important thing. Sotatercept acts as a ligand trap for members, and that is a wonderful molecule. So this is in part of the recent trial management pulmonary hypertension. I thought I need to add this. So next slide. We've almost done.
Right.
Next slide, please. So in advanced heart failure or right ventricular failure, in addition to basic ICU standard, RV function should be carefully monitored in this state. Non-invasive monitoring like NT-proBNP and troponin and echocardiogram should be done. Upper body central venous catheter, to mention central venous pressure is important. The central venous oxygen saturation need to be done. Right heart catheterization, advanced hemodynamic assessment should be done. And right heart failure, triggering factors like infection, arrhythmia, anemia, other comorbidities should be managed. The mortality in these cases is high. Next slide, please. And fluid management are most important. Most of them require negative fluid balance to reduce the RV preload. Thereby, they will improve the RV geometry and function. They may benefit, the low cardiac output state may benefit for treatment with inotropes, dobutamine and milrinone, the most frequently and used substances, and maintaining the mean systolic blood pressure more than 60 is the key objective. So the maintaining the systemic blood pressure more than 60 is the key objective when treating right heart failure, and patients with persistent hypertension may require vasopressors such as norepinephrine or vasopressin, intubation, invasive mechanical ventilation, and patients with newly diagnosed PH presenting with low cardiac output, combination therapy include IV or subcut prostacyclin should be considered. Next slide.
Imran, your time is over. It's better.
Last slide. That's last slide. It's RV failure. The mechanical circulatory failure. ECMO impeller has become an established bridging tool to transplantation for irreversible right heart failure, but occasionally it is used as a bridge to recovery also. So not only to transplant a bridge, sometimes the patient might recover if they are contributing causes to right heart failure. There's no general recommendation regarding the indication for mechanical circulatory support. It needs to be individualized. Lung transplantation remains the important treatment option for patients with PH refractory to medical therapy. I think that was last. Next slide, please. And these are the recommendations. Lung transplant. Next slide. PH complications need to be managed. Atrial arrhythmias. Next slide. And hemoptysis can occur, pulmonary artery aneurysm rupture, dissections. So even for hemoptysis, embolization in the severely morbid patients, embolization of bronchial arteries, which we are doing, can be done to decrease hemoptysis. That's, I think, the last slide. Thank you so much for hearing me out, and apologize for the glitches occurring. Thank you, sir.
Okay, Imran, it was a wonderful this disposition of the subject. It's a difficult subject. We'll come to it later on with during the discussion.